Benvinguts en aquest acte de commemoració dels 25 anys del Centre d'Estudis Epidemiològics sobre les ITS i el VIH, el SARS-CoV-2. Com alguns de vosaltres sabeu, habitualment fem una jornada presencial a Cosmocaixa. Cada any escollim un tema. Aquest any no ha pogut ser per raons òbvies relacionades amb el Covid i, per tant, hem fet aquest webinar que espero surti bé i que d'entrada ja ha tingut bona acollida perquè hi ha hagut més de 150 persones registrades. Buenas tardes a todos y todas y bienvenidos al acto de conmemoración de 23 años del SARS-CoV que hacemos por webinar. Welcome to everyone who has joined us from other parts from Spain to this commemoration event of the 25 years of our center. Hi ha gent de diverses nacionalitats i països, des dels Estats Units a llocs del nord d'Europa i molts països d'Amèrica Llatina. Per tant, intentarem parlar a poc perquè el traductor pugui fer la seva feina correctament. For those of you who will need translation, in the right part of your bottom screen, you have a button called Interpretation. If you push it, you can choose the language that will be translated for you. It could be English, Catalan, or Spanish. The other thing I was asked to ask you, for the ones who are not speaking, is to switch off the micro and the camera while not performing, because that helps a lot the communication for everyone else. És un plaer, doncs, donar pas a la inauguració de l'acte. El SISCAT, com després explicarem, ha tingut una llarga història i, per tant, com totes les organitzacions, moments més fàcils i moments més difícils. L'últim atzucac va ser la necessitat de buscar uns nous espais, fa un parell d'anys ja, i en aquest últim procés hi ha unes persones que van ser clau i que precisament ens acompanyen en aquesta inauguració. Per tant, és un doble plaer comptar en primer lloc amb la consellera de Salut, senyora Alba Vergés, amb la directora general de l'ICO, doctora Candela Calle, i amb el doctor Joan Colom, director del programa PKVIT. Tots ells van ser una figura clau en aquests últims anys i, per tant, el nostre agraïment des de part del grup i unes gràcies especials per acceptar ser avui aquí amb nosaltres. Per tant, sense més preàmbul, m'agradaria donar la paraula a la doctora Calle, que, com he dit, és la directora general de l'Institut Català d'Oncologia. Per aquells que no sou d'aquí, l'Institut Català d'Oncologia és la institució que des de fa uns anys acull el centre i, per tant, hem tingut l'ocasió de treballar conjuntament amb ells en diverses ocasions i temes. Doctora Calle, sisplau.
Doctora Calle, I give you the floor. Good afternoon. Thank you very much, Dr. Casanova, Regional Minister Valles, Dr. Colom. Good afternoon and welcome, all of you joining us for this event. It is a true honor for me to be able to share this welcome, because we're welcoming the 25th anniversary of a successful story which began in 1995 as a result of the idea of the Department of Health in order to implement a program that is working in the prevention, control, and care for HIV, sexually transmitted diseases, and viral hepatitis through the monitoring of epidemiology and through the monitoring of the results and treatment and the results of the research. This history is long And last year, when we were inaugurating the facilities that Dr. Casabona was alluding to, well, we needed to celebrate that, and we're truly celebrating that. And it's true that we're doing so in a different manner because we cannot stretch our hands in person, but it's emotional nonetheless, even though we meet virtually. And this 25th year-long successful history means that this SAISCAT has been hosted by the Catalan Institute of Oncology, and there is a lot of synergies between the leaders of the ICO, the Catalan Institute of Oncology, and we have Dr. Xavier Bosch and Dr. Alemany, and we have found a lot of synergies in the research, and this is one of the key elements of our success story. But obviously, all projects are feasible and viable, just like this one, because there is a vision, the vision that the Department of Health once had. And I would like to thank the Regional Minister Vergés for this vision. I would like to thank Dr. Joan Colom as well for that, because whole projects need to be led. And the leadership of Jordi Casabona during all these years, with a lot of tenacity, with rigorous vigor, underpinned by high-level professionals with a lot of scientific rigor and with a high level of commitment, have turned this program a reality. And it is true, as Jordi mentioned before, that programs go through thick and thin, good and bad moments. And at all moments, we have had the support of the Department for Health. And again, allow me to thank them for that. Truly, we can think that currently that the SAISCAT is showing everything that we have done and everything that we want to achieve in the future, in the present and in the future. And we have the ability to cater to the needs and to adjust to the changing needs at the Catalan Institute of Oncology, which is a public institution, which is a reference landmark. We are really concerned with COVID to see which is the impact on our patients. We are undertaking many different studies in order to analyze the disease, the affectation, and we know that the SAISCAT is closely collaborating currently with the Department of Health for all the zero prevalence studies of COVID. So as I mentioned at the beginning, I am convinced that it is thanks to them that we have had a success story, and I would like to thank you. I would like to congratulate you, and I would like to acknowledge the work of everyone that has made this possible. Thank you very much, and welcome to you all.
Jordi, you're on mute.
Jordi, we cannot hear you. Oh, apologies. Now we can hear you. Apologies for that. I was muted.
No, donava la paraula al doctor Joan Colom com a director del programa de prevenció, control i atenció del VIH, les infeccions de transmissió sexual i les hepatitis víriques del Departament de Salut.
Diseases and viral hepatitis of the Department of Health. Thank you very much, Jordi. Thank you very much, dear Regional Minister and Dr. Calle. For attending this 25th anniversary. When I was thinking about the 25-year-long history, many of those years I had to live firsthand the beginnings and the last stretch of our history. And I was reminded of certain milestones of our trajectory. And I was reminded of many of the facts that many of the colleagues will remember those milestones. We began at some years where we were accompanying in AIDS people to death. It was a terrible those were terrible times. Fortunately, currently we have undergone a radical change in the last 25 years, and we moved from that dreadful mortality rate to the living with a chronic disease currently. But many things have happened throughout these 25 years. First, we had to deal with the challenge of how to manage the information and then the surveillance system. And I remember the developments regarding the declaration of the disease, which was rather polemic, if you remember, and it was really difficult. And currently it is unchallenged, and we have surpassed the criteria of exclusion for liver transplant for HIV positive patients, for example, which was the case before. So we have gone through a lot, through an ordeal, and an important turning point might be in the year 2002 when in Barcelona we organized, and precisely it was led by Jordi. We had the International AIDS Congress held in 2002. So we have seen 25 years with a lot of tough times and good times since 1995 when the program was first created under the auspices of the regional minister Xavier Trias. So we grouped together the SACE-CAT and this structure, which is really relevant. And then later on, as highlighted by Dr. Candela in 2006, it was part of the Catalan Institute of Oncology, and we would like to thank from here all the support, the good alignment, the good relationship, the shared strategy that we have had during the last years, and which has allowed us to introduce all the necessary changes and to move forward aligned in the future. And we have seen some changes from a structural standpoint, and Jordi Casabona alluded to that in the introductory words when in April 2009, we introduced an important change in the space that we were occupying in the Germans Trias y Pujol General Hospital to moving to the Foundation Carreras and to the Research Institute Germans Trias y Pujol. And here we need to acknowledge and thank clearly two people that played a relevant role in this respect: Felipe Evarist, Dr. Feliu Evarist, who is responsible for the foundation and the Josep Carreras Foundation, and then the IGTP director, Manel Puig, and currently is directed by Jordi Baratina, who is with us today sharing this webinar. So more than 30 professionals of the SACE-CAT, highly prepared and high level and high performing scientists have allowed us to work in the most accurate manner. So that was an important milestone, turning point that has allowed us to move forward in this process, and this leads us to dealing with COVID. And this is the protagonist of our event. And in 2020, in spite of the difficulties and the dire straits, it is a priority for the department, also the HIV, the sexually transmitted diseases, and viral hepatitis. And that's why we have streamlined strategies, programs, and even more innovative programs that introduce some innovations for early non-presence-based diagnostic systems, treatments without the need to move to the hospitals, the antiretroviral treatments, etc. And at the Department of Health, we have had a lot of support for the prevention, control, and care of HIV, STDs, and viral hepatitis, which I have the honor of presiding, and which is responsible for streamlining the actions to respond to HIV. The SACE-CAT is a unique institution in Spain. And it includes, obviously, those infectious diseases in addition to the HIV, obviously, in order to have an efficient response. The SACE-CAT model, as really well expressed by Candela Calle, is a successful model, and it is a reference role model inside and outside our boundaries. And we have the monitoring and the applied research, among others, and the surveillance, and it is used for the streamlining of strategies, and it is jointly deployed with the community institutions. With initiatives like this one regarding early diagnosis or the measurement of impact of COVID in the healthcare units. We are going to continue to place our bet on these strategies, and we want to continue to integrate the research of all three diseases, the HIV and STDs. The first thing I did when I took on the hepatitis, I introduced the monitoring and surveillance of HIV, STDs, and viral hepatitis. No one challenges now the importance of surveillance services as part of the prevention strategies, which is of the utmost importance. And we need to have thorough and agile systems that allow us to objectify reality and face the challenges. And the prophylactic projects bring together the healthcare units and the monitoring strategies of the SACE-CAT, and this allows us to monitor and analyze this tool, which is benefiting 2,500 people in Catalonia. This event can be used to raise awareness among everyone, because here we have the presence of 14 countries and 180 people. We want to highlight the importance of the role played by the SACE-CAT, because if we can translate the reinforced surveillance policies into tangible policies, we can build a society that can make us achieve the goals that we have set in Catalonia, that will make us reach the objective of 95, 95, 95 for the year 2030. Right now, the figures are 1990, 93. And we need commitments, responses, and responsibilities in light of the Day of AIDS in 2020. So I would like to thank the director of the SACE-CAT and the rest of the team that make it possible to move forward towards this future and this present situation, and which allows us to face with all these tools all the different challenges that we're heading for. So thank you very much for the job that you have put in, and the one that you're putting in, and the one that we need to undertake for the future. And you will have all our support. And I would like to congratulate and thank our partners, the Catalan Institute of Oncology and the Director General Candela Calle, for making things easier and accompanying us in that path. And I would like to thank the regional minister for all the support, all the political institutional support that they have lent from the beginning, and for prioritizing this project. So thank you very much for that.
Moltes gràcies, Joan, per les teves paraules carinyoses i encoratjadores. És un plaer, doncs, ara passar la paraula a la honorable senyora Alba Vergés, consellera de Salut de la Generalitat de Catalunya, que coneix el centre i que també ha sigut un suport clau, no només des de la conselleria, sinó també en etapes prèvies.
Thank you very much. I give you the floor. Thank you very much, Dr. Casabona. First and foremost, allow me to congratulate you, and we need to congratulate ourselves when we want to congratulate outwards. It seems like we're not including ourselves in that, and I believe that these 25 years are a testament of a good work, and the fact that we have research centers for epidemiologies for HIV, STDs, and viral hepatitis, which is a pioneering center and which is connected to the world. comes to show the strength of our country. And here we are doing this virtually. We would have liked to do it differently in a full-blown manner, physically in presence, but we need to celebrate this. We need to meet, and we need to be able to explain that we're here after 25 years. And I think that now more than ever before, especially for those people that, because of the generational gap, did not live the beginning of the AIDS epidemic. Well, it is now that we can make use of the situation of the COVID to explain what the early stages of uncertainty and fear of the AIDS epidemic meant. There was a lack of knowledge. It was an unknown impact, full-blown impact, and we did not know which were the effects, and people wanted to respond to the needs of the patients, which who were getting worse and worse every day. And as Joan Colom reminded us, we felt powerless, so we sometimes could just accompany the patients. So I would like to thank Joan Colom for his engagement in this program, and I would like to thank Andela and Calle, and I would like to welcome absolutely everyone. I think that we have many people from many different countries, the US, Guatemala, and many different countries present here accompanying us in this meeting that celebrates the 25th anniversary of the creation of the SACE-CAT. And we have Dr. Sten Bermud from the School of Public Health of the Yale University, Dr. Sten Bermud, among others. So we have 180 people gathered together around something that is still ongoing, even though it has changed a great deal. And currently we are amidst a world-scale pandemic of the COVID. And we're talking about two pandemics, which are completely different, but where the impact is changing lives. And obviously that, just like what happened at the beginning with the creation of the program and the creation of the SACE-CAT as well, I'm sure that as a country, we're going to be able to move forward to bring forward better public policies. I think that this has been a success story, a success model. We have gathered the best expertise, bringing together the know-how of the universities, and we have not, well, we are a small country, but we're an open country, and we have always had a broader view, and we wanted to share our know-how, always at the cutting edge of technology. As mentioned at the presentation, we have known each other before I became a regional minister with Joan, and he's one of the first experts that I had contact with as responsible for health policies at the Parliament of Catalonia. And this is something that I am reminded of. He was explaining me a lot of things about a world that was unknown, and I have been able to apply all this wonderful knowledge that he opened my eyes to. And I think that this is a successful model, and I believe that there is no possible public health system without good public policies. That's why it is important to bring together the maximum expertise and know-how with the people that need to implement and design these policies, and how to design them. As I often say, co-participation is key in the designing of policies, and not just in the implementation, but also in the design stage when it comes to streamlining the public policies. And this is the reason why this has been a successful model. And we need to link the HIV with sexually transmitted diseases and viral hepatitis, which is what we have done in our program for the prevention, control, and care. And this is something that we had been doing before, based on the expertise and on our experience, and also the community network of our country. And this has been an important brand and milestone that we don't want to abandon. The epidemics have a social community aspect, which is really important, and everything that we have been capable of learning with the HIV and the sexually transmitted diseases are of great use in that respect, not just from a conceptual standpoint, but also when it comes to designing a response. And it cannot be just a merely scientific kind of response. We cannot just talk about vaccines. We cannot just talk about treatments. Rather, we need to talk about what an epidemic means and how they are transmitted and why is a virus transmitted and which are the means of transmission. And this is something that needs to be explained in an understandable manner, because the response to a pandemic like the COVID needs to come from the society, not just from the scientists, but from societies themselves. And I'm really happy because with SACE-CAT, we are collaborating a lot in the framework of the COVID pandemic, with some projects that were undertaken, hosted by the Projects of Innovation, with the Centinela schools, for example, which is something that brings together how important it is to learn and to share knowledge. And I think it's really important. We streamline policies in the case of COVID, where we showed that we don't want to break the education of our children in our country. So we need to accompany all of this in the school projects. And this is something that is coming together very nicely in this Centinela school example. And I would like to give you all my support. And in the Catalan Institute of Oncology, we have lent a lot of support. And I think that this has been really important in different moments. And I would like to thank the Catalan Institute of Oncology and the SACE-CAT. I know that I haven't gotten lost at any point thanks to you, because I know that we need to incorporate the HIV, STDs, and viral hepatitis. And in the program, we have included the goals set by the WHO and the 2030 objectives of 95, 95, 95, etc. And these are goals which are well, rather ambitious, and they are embedded in our program. And I'm sure that we would haven't dreamt of being capable of tackling these issues so efficiently. I think that the COVID epidemic is teaching society, thanks to the tough times that we have gone through. And I, as a regional minister for health, feel currently with this intervention that I am paying tribute to the people that were working before me, Regional Minister Trias before me, that accompanied you from 1987, where they created this program of the 1995 program. And we need to create, and then they created the Center for Studies, in addition to some other centers for research. And this was momentum created by my predecessors that had the vision of how important it is for people. And taking into consideration all the components, the HIV, STDs, and viral hepatitis, because society is filled with inequities, and this is an important factor. And this is something seen in the pandemics: more prevention, more promotion of surveillance and public health translates into better health, be it during a pandemic or without that. I don't know if the AIDS or COVID will disappear for good. We don't know. Probably not. It is one of the most difficult things to eradicate. To eradicate a disease is a very strong word. It's a very powerful goal, a very powerful wish. But I think that thanks to the good knowledge, we have had to learn to face it and to live with it with all our energies and momentum. And here we are to support you. And I would like to congratulate you all. And I feel that I'm paying tribute to the people before me that preceded me in this 25-year-long history, all of them with their important contributions. Thank you very much.
Moltes gràcies, consellera.
Thank you very much.
Molt bé,
dear
doncs,
Regional Minister.
Moltes gràcies per les vostres
Thank
paraules
you for your kind
encoratjadores. Crec
words
que
and
l'equip les ha
encouraging
rebut
words. I believe that our team
molta
has
il·lusió
welcomed
i
them
ànim.
with
I ara passaríem
a
a
lot
la
of
segona part de
enthusiasm
l'acte,
and
que és
excitement. And now we move
una
on to the
taula
second
rodona
part of
amb el
today's
tema que
event,
aquest any hem
which
escollit
is a
i que,
roundtable with
no
the
podia ser
topic
d'una
that
altra
we have
manera, és
this
el
year,
Covid
and
i
it
aquest
is
concepte
the
de
COVID and
sindèmia.
the
Abans,
concept
però,
of
jo faré
syndemic.
un breu
Before that, let me
recorregut
just
sobre algunes
go
de les coses
through
que hem fet
some
aquests
of
25
the
anys.
things that we
Algunes ja
have
s'han
done
comentat, simplement
throughout these
aterrar-les
25 years. Some of them have
una
been
mica
mentioned. I
més
just
i
wanted to
després, tot seguit, passaríem
mention them.
a la taula rodona.
And then we
For those of
will
you
move
who
on
have been
to the
incorporated
roundtable.
late, if you want translation, you can go on the right side of your bottom screen and in the interpretation bottom, choose either English, Spanish, or Catalan for translation. Thank you. Es veu, no, la diapositiva?
I hope that you can see it.
Perfecte. Bé, doncs, el títol de la xerrada ha sigut aquesta, de la SIDA al Covid, no? Aquests 25 anys. Com s'ha dit, i els que sou d'aquí coneixeu, estem en el campus de Can Ruti, on hi ha un seguit d'institucions importants i una concentració importantíssima de grups que treballen amb infeccioses i concretament el VIH i ara també amb Covid des de diversos punts de vista. Nosaltres estem físicament en aquests dos edificis, la Fundació Carreras i l'Institut Germans Trias i Pujol. La història va començar, com ja ha comentat molt bé el doctor Colom i la pròpia consellera, el 1995. En aquell moment hi havia el que en dèiem el Pla Sanitari de SIDA, que va ser l'evolució natural del programa de prevenció i control i que el vam fer amb aquests dos components, un més institucional, que es va quedar al departament, i un de més acadèmic, si voleu, o més orientat a l'epidemiologia, que va ser el CISCAT i que vam venir físicament aquí a Can Ruti. A part de la diferència d'edat que es pot veure respecte ara en aquesta fotografia, sense voler-ho, he vist una cosa interessant. En la presentació del Pla Sanitari ja va venir l'Stan Vermont. Stan, I don't know if you remember it, but you were already here. So thanks for
you were already
being
here, so thank you very much for being with us all this time.
I com ha dit molt bé la consellera, en aquell moment la SIDA tenia un impacte importantíssim i de fet va ser durant uns anys la primera causa de mort entre la població jove de Catalunya. Com s'ha dit també, l'objectiu era poder trobar un entorn on poder desenvolupar aquests tres àmbits, vigilància epidemiològica, monitoratge i avaluació, és a dir, fer servir dades dels programes pròpiament dits, i recerca aplicada, poder accedir a financiació externa, poder-la gestionar, i per tant es va pensar que un entorn menys rígid que el de la pròpia administració ho podria facilitar, i a vegades no ha sigut tan fàcil, però certament ho ha fet possible i jo crec que els resultats d'aquest temps així ho constaten. Aquest va ser el començament, aquests vam ser els primers que vam venir aquí. Com podreu veure o recordar, a part de ser gent valenta, perquè no sabíem com acabaria l'aventura i alguns vam deixar la nostra plaça de funcionari, hi ha un detall interessant que he vist al revisar les fotografies, i és que tots els senyors portaven corbata, el 100%.
having
I
their
després hi
ties.
tornarem.
100%
Va ser en aquella època, als anys 94-95, en què vam començar les grans línies que després s'han consolidat, que ens han permès treballar acadèmicament i també tenir un impacte, creiem, tant en les polítiques com en el treball de moltes organitzacions no governamentals en el terreny. Una d'elles ha sigut les enquestes bioconductuals, el monitoratge de les conductes, cosa que al començament alguns alguns de vosaltres recordareu, va ser molt difícil i poc acceptat per alguns sectors. Però vam introduir aquest concepte de monitoratge bioconductual, recollint dades de conductes, actituds i coneixement i dades biològiques de mostres alternatives, amb tests que normalment vam pilotar nosaltres abans perquè no estaven consolidats, en poblacions de risc i vulnerables com han sigut els usuaris de droga, els homes que tenen sexe amb homes, treballadores sexuals, etc. Això hem anat fent de forma repetida. És una informació que, com sempre hem intentat, s'ha utilitzat per part de les organitzacions no governamentals. Aquí teniu dos exemples de material on incloïen resultats tècnics d'alguns d'aquests estudis. En un moment determinat, un estudi que es va fer a nivell europeu va identificar que Catalunya i Suïssa tenien els sistemes de monitoratge conductual més integrats d'Europa, després això s'ha anat extenent, evidentment, molts altres països i ara és un estàndard que fa la majoria de països i ens ha permès, a més, no només col·laborar, sinó en aquest cas liderar la part de l'estat espanyol d'una enquesta europea que es fa en el col·lectiu d'homes que tenen sexe amb homes i que s'han recollit 140.000 enquestes, 13.000 d'elles de l'estat espanyol, i a partir d'aquesta enquesta hem muntat una xarxa a Amèrica Llatina replicant el mateix estudi en 17 països i 60.000 enquestes. És a dir, van ser apostes que es van començar en aquell moment i que, a part de ser útils a nivell local, ens han permès producció científica i participació en col·laboracions internacionals rellevants. Un altre d'aquest exemple és la xarxa de cribratge comunitari que es va començar el 92 amb organitzacions no governamentals de Catalunya que els hi vam dir, ajudar a recollir, començar a fer el test de la sida en aquells moments amb una benoculció, fins que no va ser després que vam introduir els tests de lectura ràpida i en aquesta gràfica d'aquí podeu veure l'impacte que va tenir introduir aquesta tecnologia en aquests serveis i com a exemple, això és una guia de l'OMS que va agafar aquesta xarxa com un exemple de bones pràctiques en el monitoratge i l'avaluació del cribratge comunitari. I fa poques setmanes s'ha publicat un article a l'Eurosurveillance precisament mostrant tot aquest temps, aquest període de temps i les dades que s'han analitzat durant aquests anys. I a més, igual que com deia abans amb l'altre exemple, ens ha servit per crear una xarxa europea amb els mateixos objectius que es diu COVATES i que ha permès ajudar i contribuir a estandarditzar els indicadors que recullen en aquests serveis i que a més fem una reunió anual, la de l'any passat amb el doctor Colom i tots els països que, si no recordo malament, són com 29 països que col·laboren en aquesta xarxa. Una altra de les coses que vam començar, en aquest cas el 98, va ser la cohort de pacients VIH positius de Catalunya i Illes Balears, el PISTIS. El PISTIS, jo sempre dic en broma als companys, que és dels projectes que més ha contribuït a fer més estreta la meva artèria coronària per les moltes dificultats i sorpreses que hem anat tenint, però en canvi ha sigut un dels projectes que crec que ha tingut més impacte també, no només a nivell institucional, sinó també en aquest cas a nivell acadèmic. Aquí teniu una foto quan vam celebrar els 20 anys, fa dos, a Cosmo Caixa, amb el doctor Miró, que també ens acompanya avui, que és el co-IP del projecte PISTIS i que el vam començar amb ells fa molts anys, i altres companys d'altres unitats de VIH d'altres hospitals. I una altra observació. Aquí hi ha només el 25% dels senyors portaven corbates. Com us deia, el PISTIS ens ha posat en l'esfera internacional, ens ha permès col·laborar amb totes les col·laboracions de cohorts que hi ha internacionals. Aquí teniu un exemple, l'ARCOR Collaboration, però també estem en una iniciativa americana important, el Causal, el Respon, i això ens ha permès cada vegada que surt una iniciativa d'aquestes estar en una posició de portar informació i poder-hi participar activament. I com ha dit abans el doctor Colom, ha permès institucions institucionalment una cosa molt important, que és generar la informació per construir els indicadors que en aquests moments tant des d'OMS com des d'ECDC es demanen als països, en aquest cas els de la cascada de serveis, amb el famós 90, 90 i 90, que com s'ha comentat, nosaltres hem pogut superar per aquest primer dintell. A més, la Marató, el PICES ens va ajudar a aconseguir un projecte de la Marató, amb l'edició de SIDA, que es va fer fa un parell d'anys, amb un projecte en col·laboració amb l'Hospital de Bellvitge, adreçant precisament l'envelliment, parlant de 25 anys, l'envelliment de les persones afectades pel VIH i tastant una intervenció per reduir la pèrdua de persones que no tornen a l'hospital per rebre tractament i veure si amb una intervenció podem disminuir aquesta taxa de no retorn. I, a més, en el context del PICES, estem elaborant, ja s'ha acabat, i espero que puguem publicar alguna cosa l'any que ve, un dels estudis, jo crec, més complets sobre qualitat de vida en pacients amb VIH, en el que hem incorporat, a part dels criteris habituals, aspectes com estigma, acceptació social, etc. Per tant, jo crec que serà una peça d'informació important per tots aquells que treballen en qualitat de vida adreçades a les poblacions afectades pel VIH. Ho ha comentat el doctor Colom, però el 2001, després de molts equilibris, vam fer un pacte amb tots els actors, tant ONGs com clínics i epidemiòlegs, de començar a declarar de forma voluntària el VIH. Ara ens sorprèn, però fins al 2000 només teníem informació dels casos de SIDA, amb la qual teníem una idea de l'epidèmia absolutament esbiaixada. A mesura que van anar sortint més tractaments, això va ser encara més important. Per tant, Catalunya es va avançar a la resta de comunitats i de forma voluntària vam començar a tenir informació sobre les infeccions, independentment de la seva situació clínica. Però no va ser fins al 2010 en què vam aconseguir que la infecció per l'HIV fos declarada de declaració obligatòria amb noms i cognoms igual que la resta d'ITS i d'infeccions. I jo crec que aquest va ser, des d'una perspectiva de salut pública, dos aspectes que vam treballar molt conjuntament amb tots els actors i que van ser importants. També s'ha comentat, el 2002 vam tenir un petit parèntesi perquè va durar una mica més que un any. La preparació va començar, de fet, el 98, la Conferència Internacional de la SIDA, que vaig tenir l'honor de presidir conjuntament amb el doctor Josep Maria Gatell, de l'Hospital Clínic, i que evidentment va tenir un impacte en la dinàmica del grup, perquè jo almenys vaig dedicar-me moltes hores a preparar-ho, però crec que també va ser un aspecte important, tant a nivell social com acadèmic, pel país, el poder acollir les personalitats que van venir en aquell moment i els 18.000 participants que vam tenir en la conferència. Aquí podeu veure dos amics, un d'ells crec que està avui amb nosaltres, el Jordi Baroja, president de CEJAS, i l'altre, el Bill. El Bill m'ha trucat i m'ha dit que li sabia molt greu, però que no es podia connectar, que tenia coses importants que fer, no sé si amb el Baden o amb algú altre, però certament ens va ajudar a posar-nos en l'esfera internacional i a poder seguir treballant amb molts sectors a nivell internacional. I una de les conseqüències que va tenir va ser que amb alguns dels beneficis que va deixar la conferència vam fer una intervenció que va acabar durant més de 10 anys a Guatemala, en el que diversos companys del CISCAT hi van poder participar, vam exportar expertesa i vam acabar fent algunes coses que s'han fet aquí, com una cohort, vam fer una cohort poblacional a nivell de país, a imatge i semblança del PICES, que es va dir Mangua, vam fer una intervenció amb treballadores del sexe demostrant l'impacte que pot tenir una intervenció preventiva multinivell i finalment es va treballar molt en profunditat el tema de violència sexual, que com sabeu és un determinant importantíssim a Amèrica Central. El 2006 van passar dues coses importants. Una d'elles és que també vam assumir la responsabilitat de les ITS i, entre altres coses, de forma consensuada amb els epidemiòlegs del terreny, vam posar com a de declaració individualitzada les bacterianes més freqüents, la clamídia, la gonorrea, la sífilis i el info granuloma benètic. Ens hem deixat de banda la clamídia per motiu de càrrega de treball, però veieu en aquesta gràfica el que va suposar en termes de tenir informació d'unes infeccions que abans d'aquest decret només es tenien números, no sabíem si eren homes, si eren dones, si eren transgèneres, si s'havia adquirit sexualment, si s'havia adquirit per una via sexual o una altra. Per tant, a partir de llavors vam tenir informació epidemiològica bàsica per poder definir intervencions més efectives. I el mateix any, i això se n'ha parlat abastament, vam fer una cosa que jo sí crec que s'ha de dir, ha sigut bàsica per la consolidació del grup, no només a nivell laboral, que evidentment és un tema important, sinó també a nivell de concepte, el fet d'haver participat, especialment en aquests últims anys, en els circuits administratius, en els procediments, en les filosofies de gestió de personal, jo crec que ha fet madurar el grup i l'ha consolidat com un servei més de la institució, com s'ha dit abans la directora general. Durant tot aquest temps hem accedit i hem pogut liderar diversos projectes europeus, sobretot en l'àmbit del diagnòstic comunitari, el Covatés i l'Eurodat, a partir dels quals es va crear la xarxa que he comentat abans, i hem participat en d'altres que no hem liderat nosaltres, com l'EMIS, el Cialon o l'Integrate, en participació d'Eurotest Copenhague. El 2015, Nacions Unides, UNAIDS, fins ara organitzava unes reunions cada 5 anys en què invitava experiències determinades de vigilància i de monitoratge de les diferents regions internacionals, i aquell any ens van proposar a nosaltres per ensenyar una mica aquesta per tal de demostrar precisament i posar en valor la integració d'aquests sistemes. I per tant, el CIBES, que és el Sistema Integrat de Vigilància Epidemiològica que s'ha construït a partir del 95, es va presentar en representació de la regió occidental. I aquell mateix any feia 20 anys del centre i ho vam aprofitar també per fer un acte al Departament de Salut amb els...
An important event gathering all the 3 regional ministers that had participated. Regional Minister Rios was the regional minister for health at the time, and the other council women like Mr. Trias and Mrs. Marina Gelli. And we have the president of the 1st of December committee, and we have the picture of the parliamentary group against the stigma and discrimination for people living with HIV. And I would like to thank the ECDC. We have Anastasia representing that because they have always taken us into consideration, and we have had the possibility of participating in many projects and many different papers. As mentioned by Dr. Joan Colom, in 2017, we created the program for prevention, control, and care for HIV, STDs, and viral hepatitis, following the model of the majority of the international organizations dealing with these infections. And the center began to work with hepatitis. And here you can have one of the outputs, which is pending publication, and we have the cascading of services for HIV, and we can see here how many people are infected, tested, and screened, treated, etc. And this is becoming a very important management tool as our treatments are becoming more efficient. So it's really important to have it in motion. And this is an important paper, the one that you can see here, in collaboration with the Program for Prevention, Control and Care in the primary health care units, where we have analyzed the time that the patients need in order to move from the primary health care to hospitals for the treatment, and the possible losses or non-returns that can happen with the different healthcare levels. In 2018, we had an episode that was sad on the one hand, because we needed to leave some premises that we were occupying. Esteve and Montserrat are packing here in order to move out, but it also had its upside and constructive part, which we mentioned before. We were physically integrated into the Josep Carreras Foundation and the IGTP, and you can see here the images corresponding to the inauguration with Dr. Carreras. And recently we have worked with more modern strategies, and one of the lines that we have devoted the most effort is the self-diagnosis and self-sampling, and we have the testate and the VIIV healthcare initiatives, and we have the possibility to send tests home to gather the sample, to analyze it, and to give the result through safe webs. And in HIV, it has worked extremely well. And as mentioned before by the regional minister, we're working also in COVID. You can see some preliminary analysis of the geographic distribution and the types of antibodies based on blood volunteers, blood donors. We have been analyzing their samples, and thanks to these, we can see a mapping of the exposure and evolution of the virus, and the Centinela school project that was mentioned before. We believe that all of this work has been translated into the support at the CIVES. We wanted to introduce the CIVES 2020 today, but we did not make it in time because this dynamic of work renders this more dysfunctional, but we will be doing that at the beginning of next year. And we can see here our position in research. We're always at the middle, we can say. And this is quite well because our realm is surveillance and epidemiological research and surveillance of the epidemiology. And the average, do you know, Alexander, which would be the average? And this was the words that I was asked at the meeting. Well, sometimes it's really difficult to translate everything into figures, and this is the good or the bad thing of our research. And none of this would have been feasible without the collaboration of everyone working at the center. People are always at the core, and they pose the most important challenges and the most important sources of happiness. They're really well prepared, and they're holding positions of responsibility in different institutions. We have PhD students, etc. So we would like to thank all of them. And it's true that there are some aspects which are worth highlighting. Rafa, for example, I wanted to mention him. He's the one that has stood by me and withstood me the most since 1992. He has had to put up with me, and for 1 year ago he was relocated, and but he received the Civil Merit Medal of the Center. And here we have the moment in which Xavi left us, and in the female sector, it had a lot of impact because he was waved goodbye with a lot of enthusiasm. And here we have Vicky, who is our satellite service at the microbiology department, and I would like to thank her for her support. And we don't let her out of the lab so much, but the rest of us have had wonderful times. And this is a picture that Esteva sent me. I did not remember that moment. And it's quite surprising. We even had some concerts on the meeting rooms. Maybe I wasn't there because I did not remember, but this comes to show the good vibes, the good atmosphere of celebration. Probably we were celebrating Christmas back then. I would like to thank all the institutions that we have alluded to previously that have lent their support, and the ECTC, because we have a wonderful professional and personal relationship, the Eurotest initiative, and I'm part of the steering committee, and we undertake many projects together. I would like to thank everyone in Catalonia with the hospital unit and the public health agency and all the surveillance unit in the territory, the ID app and the CAMFIC. And the 1st of December committee and all the NGOs that are brought together by the DEVO network, and with also STOP and SEBAS and Anbit Prevención that we have collaborated with, and then some private sponsors like the La Caixa Foundation, the VIIV Healthcare Company, and the JAI Lead companies, and we would like to thank them for their support as always. And we have gone through different stages at the center, and I would like to thank Regional Minister Mr. Trias, Ms. Jelly, Mr. Comín, Ms. Vergés, and they have done everything possible so that our center could become a reality. And I would like to thank Dr. Colom, Dr. Calle, Dr. Clopez, Dr. Feliu, Dr. Butch, and Dr. Clotet in this last stage, because without them, this relocation would not have been possible. And I would like to thank the current team. I believe that we have an excellent team, and we are at the best position we could think of. I'm not going to mention all the names because there's a lot, and there's some people who are new hires and they're not in the picture, but please feel included. I would like to thank them all. And as you can see here, there is no tie whatsoever. No gentleman wears a tie. So if anything has happened during these 25 years, is that we have lost the ties. That's it. Thank you very much to all of you for making this possible, and congratulations. And when I mean for making this possible, I'm not talking about getting rid of the ties, but I'm talking about all the nice work that we have undertaken all throughout these 25 years. Thank you very much. This was just to frame the comments on the center, on the SACECAT. I wanted to illustrate everything. And there are no questions still, but if later on you would like to make some comments regarding this period of time and the role of the SACECAT, I encourage you to do so. So we are going to move on to the round table. There are some technical presentations which are going to be held. We have chosen the concepts of syndemic, the concept which is more or less recent in the healthcare, but more consolidated in the social sciences realm, which has to do with what you can see here. There are some transmission determining factors. There are many different factors, of a biological nature, like the viral load. And there can be some individual patterns like behavior, using condom or not, and then some structural and community-based parameters. So prevention needs to take into consideration all of this, and this is where the concept of combined prevention emanates, and which currently is monitored by the large international agencies. Linked to this, we have the syndemic concept. Syndemic is the same as synergy. We're talking about two illnesses that are boosted mutually, but on a population level. It is a concept which is widely used in social sciences, but in terms of AIDS, and in AIDS it has been used a lot. And it is clear that in AIDS there are many syndemics that have to do with well, certain factors that have to do with drug consumption and some healthcare parameters, or some factors of sexual violence, and the HIV has seen this concept being used. And Richard Horton said that COVID is not a pandemic, but that it should be considered a syndemic, because many of those elements are also present there. And then there was an answer through a letter saying that in addition to that, we should also include the ecological dimension in terms of its origin and the impact in the mini ecosystem, and how it has an impact on the spreading of the diseases. So with COVID, we have a clear relationship with non-transmittable illnesses like respiratory diseases, diabetes, etc. And we have doubted how to talk about the relationship with COVID. And evidently, there are some social structural elements like the surface of lodgings. It's more difficult to stop the spreading of a disease where we're talking about a lodging which is completely crowded. So clearly, the concept of syndemic is applicable to COVID, and this is what we wanted to highlight in today's roundtable, without setting aside the impact of this pandemic and on the healthcare services and the different services. The cancer patients have been affected by that, but also some other kinds of patients seeking for a diagnosis of HIV and STDs and the viral hepatitis. It has had an impact. So with this idea in mind, we have built this session. We're not going to deal with all the aspects entailed in a syndemic, but we'll have the honor of counting on the presence of Dr. Sten Vermund, the Dean of the Yale School of Public Health, and he's going to talk about a global perspective. Dr. Anastasia Faris, focusing on the European realm. Dr. Miro, who is going to review the therapeutical aspect at the clinic hospital, a senior consultant for infectious diseases, and Dr. Juliana Reyes of the CISCAT, who is going to talk about co-infection, and Dr. Daniela Rojas from Coalition Plus, who is going to talk about the impact on community-based services. So therefore, I'm going to give the floor to Dr. Vermund. The idea is that all speeches should last for 15 minutes, and at the end, we'll open the mic in order to, we'll open the chat rather, in order to gather all the questions. You can do it on the go. And you have the Q&A button at the bottom. You can post the question in any language, and we're going to bring them together and we'll try to share them at the end. And if you need interpretation services, you can do that using the button below where it says interpreting services. And you can pick the language of your choice, English, Spanish, or Catalan. Therefore, I'm going to give the floor, without further ado, to Dr. Sten Vermund for his presentation. Sten, I give you the floor.
table from a paper that we published in the Journal of AIDS earlier this year. And we had the circumstance in Wuhan, China, where persons living with HIV were not easily able to secure their antiretroviral therapy because the city imposed a very strict lockdown because COVID-19 was out of control, as you all know. And the community-based organization, the Wuhan LGBT Center, mobilized a home delivery system, just like your takeout food, but takeout drugs. And they delivered to about 1,600 people who were eligible. 900 of them wanted their drugs delivered to their home so they could stay safe. And this created an opportunity on the opportunistic research side for us to do a name match between the HIV system and the COVID testing system. And we got the Institutional Review Board approval and tried to do it in a highly ethical way. And we were able to identify 12 individuals, first 37, but ultimately 12 persons came into our study. And these are persons who were dually infected with HIV and then became infected with COVID, with the novel coronavirus that causes COVID-19 disease. This is a little bit about the characteristics. The age was ranging from 25 to 66 with a median of 36. Most were men and most were on ART. But the point of showing this slide is to highlight the 3 adverse events in the cohort. 9 persons had extremely mild COVID-19 disease, and 2 persons had a disease that landed them in the hospital, and they were quite seriously ill. And 1 person was mismanaged outside of the hospital. When he got ill, he was told to stay at home, and he died at home and never had a thorough workup in the hospital. He was on antiretroviral therapy, but he got very seriously ill and functionally never got medical care. And we have very little information on that individual. But 2 individuals were diagnosed with HIV at the time they came into the hospital. One of them shortly before, but refused ART. And then the other was a friend of this person's who got ill and was diagnosed with HIV. So they had very advanced disease, and they had very high viral loads, and they got very sick from COVID. So we are positing a hypothesis for your consideration, which will require a lot more research. But it is plausible that the profoundly immunosuppressed HIV-infected individual will suffer grievously from COVID-19, having very little coherent immune response to a devastating viral disease. But it is also plausible, and this is not a fact, this is just a hypothesis, that the persons well managed with HIV who still have some immunosuppression, perhaps they will not overreact. Their immune systems will not experience that cytokine storm, that dysregulation. Now, our sample size of 9 people is not very much, so this is just a hypothesis. But we would argue that it's plausible that a well-managed HIV-infected individual may have an immune system that is not subject to this hyperreaction and this extreme overreaction that has killed so many people with COVID. So take that for what it's worth. It's just a case series, and obviously we'll need much more definitive study to evaluate this. Let's talk a little bit about healthcare. We have the pre-lockdown consequences. The ease of global travel is obviously not there, and the ease of introduction and viral spread was substantial before we had the lockdown. In the post-COVID phase, we've had a compromise in HIV/AIDS care. That's been clear to all of us who are in the loops of HIV/AIDS care. Some patients have sort of vanished for a number of months. They're afraid, they're in their homes. Other patients have needed more aggressive care, but have avoided it. We've had circumstances of depression and isolation, and obvious economic difficulties. Persons living with HIV may lose their jobs, they may lose their small businesses, and then we've had supply shortages within our care environments, as with personal protective equipment. So let's just talk a moment about these and add one, which is public health strategy differences. So different societies have different approaches. I just highlight Sweden here, where early in the pandemic, they had 7-fold higher death rates compared to Denmark, and something like 10-fold higher death rates compared to Norway. And even today, that difference persists at about a 4-fold difference. So one can substantially influence the pandemic depending upon the degree to which one adheres to classic public health prevention measures for respiratory viruses. Sweden was much more relaxed, as you all know, and had the erroneous view that they could invite herd immunity through natural infection, which was an absurd concept from the beginning, and they've suffered grievously from it. We looked at transcontinental spread to Africa in an opportunity that we had to study Egypt, and we looked at healthcare worker issues in China early on. We published this paper from Khattab on how coronavirus disease entered Egypt. It's a little too long a story to share in the brief time we have today, but if you're interested, it's a short article, and it describes how international business travel from Egypt to China and back again introduced the first cases in that country. We studied the access of personal protective equipment. We found some hospitals in China had shortages and other hospitals were well endowed. And we were able to correlate healthcare worker attitudes towards availability of personal protective equipment. Healthcare workers were more than happy to attend to coronavirus cases. They were more than willing to engage the challenges that faced them, but they experienced tremendous stress and tremendous job dissatisfaction when PPE was unavailable. And this won't come as any surprise to any of you. We also looked at an interesting group of medical students who were studying in public health schools at the time of the outbreak. We studied them both in Wuhan and in Beijing. And we found a tremendous sense of social isolation, depression, and anxiety in this pool of extremely well-informed healthcare students. So these were medical students doing advanced training in public health. You couldn't be better informed than these students, and yet they themselves had tremendous sense of social isolation and anxiety and some depression. So one can imagine how laypersons might be reacting in this circumstance. So a lot of substantial healthcare impact, and I think we all know that healthcare was delayed for so many people because of the limited capacity of hospitals and the anxiety of clinics to stay open in a pandemic setting. Let's close with a few comments on economics. How might public health responses preserve economic well-being? We did some early work on prevention spread with use of masks. We felt that there was a lot of nonsense being spewed by public policy people and politicians, sometimes even public health people, about how masks didn't have an evidence base. And it didn't take me 20 minutes on the PubMed to find very substantial evidence base supporting mask use for mediating influenza pandemics and other respiratory diseases. So I thought this was nonsense, and I worked with some of our economists, and I'll show you a slide in a minute. We believe that an early and aggressive response could lead to an early recovery and reopening of society. Unfortunately, the President of the United States didn't agree with us, and the United States has done one of the worst jobs of any country in the world in operationalizing a disciplined response. So what lessons from HIV might apply to COVID? Well, social determinants of disease drive health inequities and disparities. Jordi alluded to this earlier. An indolent public health and hospital system response will ultimately cost you time and money in the long run. You can do much better with prevention than treatment at the end of the day in terms of economic savings. We've had slow and ambivalent prevention measures in society. I mentioned the United States, I mentioned Sweden. We've had anemic pandemic preparedness. We've had in the United States a pandemic preparedness report that was updated in 2017 by the CDC that spelled out all the things that we should have been doing. And we didn't do them, and therefore we got caught, as we say in English, with our pants down in 2020. We've had shortage of beds, ventilators, PPE, healthcare worker shortages, and compromised healthcare needs for other chronic diseases in this time period. Elective surgery delayed, which sometimes could be life-threatening, actually. We've had stigma and systemic discrimination. I'd like to highlight ageism as a problem in this pandemic, which reminds all of us about homophobia earlier in the epidemic and the attitudes that were had towards people with substance use disorder. And that fed, I think, a slow response, particularly in my country. And misinformation, a contempt for science, was seen at the highest levels, whether you're talking about Thabo Mbeki and AIDS denialism in South Africa, or Ronald Reagan, ostrich head in the sand in America, and then fast forward to Boris Johnson and Donald Trump and others. So I think there are many, many parallels, and the historians will be writing about these parallels for years to come. So we sought to address this mask debate early on. We made a simple observation that countries with historic mask use, like South Korea, Japan, Singapore, Hong Kong, had leveled their curves much faster than countries that did not have these traditions. And that was ironic because those countries were actually closer to China, had many more contacts with China. There were 16 nonstop flights a day between Taipei and Wuhan in December and January, and yet Taipei was able to protect itself with mask wearing and other measures. And we issued these policy recommendations for the 1st of April in our preprint, and on the 16th of April in our formal publication. And I don't think we have time to go through them, but I think we were right. I think that masks should have been used right away at the beginning of the pandemic. I think that people at the highest levels of government in the US, Europe, and elsewhere, even WHO, did not have a clear message on this. I think it was a missed opportunity, and thank goodness we've caught up and are doing it more right now. At least many of you are. We're still struggling in my country. So I'd like to thank the organizers for this invitation. I've been a proud admirer and occasional consultant to CSCOT over these many years, and congratulate the organizers for an extraordinary day. And Jordi, a special thanks to you.
Thanks, Stan. Thanks for your presentation. Okay, we can move on to the next one. So I will ask Anastasia Parris from ECDC to give us the European point of view. Anastasia, thanks for being here, and the floor is yours.
Thank you so much, Jordi. I am sharing my screen now. Hopefully you can see the slides. going through. Is it okay? Give me a shout if it's not.
It's okay.
I want to thank you for inviting me to take. It's okay, great, good. Thanks. Thanks so much for inviting me to take part in this celebration. Like Stian has also said, it's ECDC's had the honor and privilege to collaborate with CSCAT over the years, and you've been an instrumental partner to us in a lot of the most important work that we've done especially in the disease program on HIV, hepatitis, and STIs. And you already showed, Jordi, some of the guidance documents, for example, that you have participated in the expert group to produce, and we are really, really grateful for that. And we also commend your leadership. You've really promoted such an excellent model in your region, and it's been an inspiration to many other parts of Europe and beyond. And so we look forward to see what the next 25 years will bring, and look forward to continued collaboration. My input here is just going to be a few minutes on the epidemiology of COVID in Europe and on how this impacts vulnerable groups, including HIV testing in particular. And so at ECDC, we are collecting the global data on COVID and publishing this daily. And we all know by now there's been many cases of COVID globally, over 67 million as of today, 1.5 million deaths. And interestingly, many of us who work in global health are often focused on, in particularly on sub-Saharan Africa. We haven't seen so much COVID impact there as of yet. There's also less testing capacity, but there is testing happening. And only 3% of all cases and 4% of deaths are in Africa. A much larger share in the Americas. In Asia, about a quarter of cases and 18% of deaths. And then here in Europe, we have had a pretty high proportion of cases and deaths. And we can see this second wave, which has really hit, especially the Americas and Europe, quite intensely. If we look just at the EU countries, where ECDC works a bit more, we've had over 14 million cases in our region and over 350,000 deaths. And most of the cases are in the largest, most populated countries in Europe, in France, Italy, UK, Spain, and Germany. But a lot of countries in Central Europe are being hit very, very hard now. In particular, Poland, Czech Republic, Slovenia have really high rates per population, especially in this second wave. It's also well known that age and male sex are determinants for more severe outcomes of COVID-19. And this graph is maybe a bit hard to digest, but just as we move to the older age groups on the right of each category, we see that a greater proportion of people, for example, are hospitalized in the A graph, or in the middle there, die as a result of infection with COVID. And we know that we see this more differentially in males than in others. ECDC has done some modeling to look at what happens. This has impacted our lives so much, and there have been a lot of very strict measures put in place which have changed the way that we work and the way that we live. And so a lot of countries, in response to the second wave, have implemented lockdown, stay-at-home measures, even some closures of schools, and have started to lift these recently. So the team working with us did some modeling and looked at if you start to relax measures on this week, on 7th of December, what would be the expectation in terms of a resurgence in hospital admissions. And they found that probably we would likely see the impact already before Christmas if measures are lifted now this week. And they compared that to lifting of measures closer to Christmas, which many countries want to do, at least allow people to celebrate the holidays together, and found that already the impacts in hospital admissions would likely be seen the first week of January. This is on EU level, and of course may differ within countries. And so we're trying to encourage that it may seem a bit early overall in the EU to start really relaxing the measures, and we feel worried that we'll see a third wave that could be even stronger. These measures, physical distancing and hand hygiene and staying at home, using face masks, as Sten has mentioned, they are effective, and we've seen that they really work when they're put in place in combination in settings. They need to be tailored to the situation. But the difficulty with some of these measures is that they have impacted all of our lives, but they've impacted some people's lives more severely. And a lot of those have been the more vulnerable populations that we work and live with in Europe. And so we've really seen that this has been very, very difficult for some parts of the population. And at ECDC, we tried to look at the medical vulnerabilities, and so people who are at risk of severe disease and death. So those would be older individuals, those with comorbidities, and then also socially vulnerable groups. And so maybe they're not at risk of a more severe outcome if they were to, but the measures put in place may make it more difficult for them or have a greater impact on them accessing services that they need and making life much more difficult. And a lot of individuals, back to the syndemics, fall into multiple categories and have both social and medical vulnerabilities, and often maybe more than one social vulnerability. ECDC did a guidance on this topic already in the summertime, actually, and we looked at trying to give some best practices and guidance to countries on addressing these populations in the midst of the COVID pandemic. And we focused on these populations, so ethnic minorities and migrants, lesbian, gay, bisexual, transgender individuals, and then those who are medically vulnerable. Homeless populations, those in abusive household settings, those with alcohol or drug dependence, people with disabilities, and sex workers. So as you can see, it's a very, very diverse group, and of course not comprehensive of all vulnerable groups in Europe, but these were populations that we looked at, both literature and a member state survey, to try to get some understanding of best practices. A few of the results, these all cite other places, but for example, the impact in people with substance abuse disorder. We have seen that those who have cocaine dependence or opiate dependence had a much higher probability of having a COVID-19 diagnosis as well. And so there was something about those which had much higher odds of COVID exposure or COVID diagnosis. And the recommendation in our report and with the expert group that we worked with was to screen and treat substance dependent individuals as part of a comprehensive strategy to control the pandemic. We also saw in this population a lot of disruption of service provision, especially those who were using opiate substitution treatment or accessing needle and syringe programs. There were often disruptions in services or people who were sort of lost to follow up. But also a lot of very interesting and quite heroic measures by community organizations to go mobile where they hadn't before, to change regulations so that take-home packs were permitted where that hadn't been possible previously. So we saw a lot of good examples to address the challenges to reach this population. We also saw of COVID in some migrant populations in Europe. The UK has shown all-cause mortality was much, much higher, especially in groups from Central and Western Africa and Southern and Eastern Africa, as well as some other regions. In Sweden, they did an interesting analysis looking at country of birth, and they adjusted for age, for sex, for education, household size, illness, income, and found still that migrants from Lebanon, Syria, Turkey, and Somalia had 2 to 3 times higher COVID mortality as compared to the Swedish-born population. We partnered with Hornet, which is a gay dating app, and did a really rapid survey last spring of some of their users. And this was just a quite rapid analysis, but we got over 2,000 responses from a wide variety of countries, and found that many men were reporting economic and mental health consequences of, at that time, it was stay-at-home measures in nearly all countries globally, but also a lot of interruptions of HIV prevention and testing, care and treatment services for those who are HIV positive. And these were greater among those who were from a racial or ethnic minority category or migrants to the country. A very small proportion of men reported selling sex were greater in that population as well as those who were socially disadvantaged. And this speaks again to the syndemics where populations that have multiple vulnerabilities seem to have been hit hardest by COVID. And this is something we recognize from the HIV pandemic as well. CSCAT collaborated with ECDC, and it was led by the Eurotest initiative. A couple weeks ago, this article came out where countries across Europe were surveyed and asked if the HIV, hepatitis, or STI testing services that they were providing had been impacted as a result of the pandemic. So they compared one quarter last spring to the quarter in 2019 of the months of March to May. And there they found that over 95% of all service providers said that there had been a decrease of some magnitude of testing provided. We then asked for the period following, so in sort of the summer months of 2020, what happened. And we did find somewhat of a stabilization in some countries, or some service providers reported that they were able to catch up, do a bit more testing, or stabilize their testing, but still over 50% reported that testing volume was still had declined compared. This worries us a lot because if we are not testing, we are not finding cases early, we are not really doing that continued work that we were starting to do quite well, I think, in recent years of finding cases, people who were infected with HIV earlier and linking them to care. On COVID cases with HIV, we have a bit of data at ECDC on people who have been notified with COVID who also have an HIV diagnosis. And that's the pie chart on your left. And so of the nearly 2,000 individuals with HIV who have been reported as having COVID, the outcomes tend to be that about a third of cases are mild. Nearly half of cases are hospitalized. Some of them are, those in gray, are admitted to ICU once hospitalized. And then a little bit more than around 15% are fatal. So this is a particular population of cases that were reported where all this information is available. But if we compare the group with HIV to the group of all COVID cases, we find that there's some more severe outcomes in the HIV group. This data, though, isn't controlled or isn't done for gender, age, and comorbidities, which is really quite important. And I know this is a lively discussion which is ongoing right now with regard to the vulnerability of people living with HIV and whether they should be prioritized, for example, for vaccines. So we will have to do this analysis really to do a fair comparison. But just to say that of cases that do have HIV, we know that many people living with HIV now are in older age groups, do have comorbidities, and therefore would potentially have greater risk due to COVID, due to these other things, not necessarily due to HIV status. And just a final remark around the testing data that I showed you, we are concerned that less testing is happening in Europe, and therefore we will have difficulty in 2020 to really understand our diagnosis patterns. This is data from Poland shared by Magda Rosinska. And the red these are different regions within the country, and the red are the diagnoses that are made in 2019, blue are in 2020. And generally as a whole, we see that in 2020, far fewer diagnoses are being made. But we also know that far fewer tests are being done. And so in the testing network, these are months over the year, and the gray bar is the tests that are done in 2020. So really a big reduction, especially in the middle of the year, but also continuing out. And so this does lead to worries with regard to what we'll be able to conclude from surveillance going forward, or at least in the year of 2020, which is a year that we want to report on our midterm progress on the Sustainable Development Goals. So there were some good practices. I mentioned a couple, but these were identified in the survey that we did in the report that I referred to. And for example, moving some services online was mentioned a lot. The community engagement approach and a lot of outreach done by community organizations was also mentioned. And there were some new models and organizations that hadn't done outreach previously moved into that territory, sometimes with very positive and excellent results. Really good collaboration in some instances between national and regional authorities and civil society, where sometimes extra funding was provided to reach vulnerable groups. And then flexibility with regard to the interpretation of legal policies, such as the ability to maybe take medication home for longer periods of time, including opiate substitution treatment, or allow services to be provided by peers where they hadn't been allowed previously. So these are some examples. There are additional ones that we don't have time to get into that may change the way that services are provided going forward. So in conclusion, COVID-19 has impacted everything about the way that we're living and working in Europe, particularly in the field of HIV. And there's definitely been a disproportionate impact on vulnerable populations, many of which, a lot of this data is not yet collected, and we're not able to even measure the impact, but need to figure out ways to do this. Civil society organizations have made a very big contribution during the pandemic to date, as they have before the pandemic, but have really done this. And this was identified in our survey in the area of people living with HIV, but also beyond, and in a lot of other groups as well. And there are these kind of strategies that have come up, and I think that they will impact the way that services are provided, that HIV care is given in the future. Things will not be the same, and we need to take the positive lessons learned and apply them. This overlapping vulnerabilities is extremely important, and it means that we need a coherent policy response so that already the problem that we had pre-COVID of fragmented services for mental health, for substance abuse, for physical disease health has really shown our weaknesses in this pandemic, and we must address this urgently. And the concerns I mentioned about surveillance and how we will be able to measure whether we are achieving the Sustainable Development Goals is something that we'll need to look at and improve going forward. And then hopefully we can see this crisis as an opportunity, and maybe this can be a catalyst in rethinking the way that we are supporting the vulnerable people in our societies. HIV has definitely started and opened that discussion, but I think that COVID has made it very, very real, and maybe we can have new stakeholders and partners involved in that discussion that haven't been at the table before. So with that, I thank some colleagues internally and externally who've contributed here, and thanks ISCAT, and congratulate you once again on the 25-year anniversary. Thanks so much.
Thank you very much, Anastasia, for your talk. Very interesting. The next speaker will be Dr. Miró from Hospital Clinic, who will be addressing some lights on treatment for SARS-CoV-2. Josep Maria, gràcies per ser-hi i endavant.
Moltes gràcies per la invitació.
Thank you very much for this kind invitation.
Moltes gràcies per la invitació. No sé si es veu la presentació.
The invitation. I hope that you can see the presentation on the screen.
Perfecte. Són Jordi, més de 30 anys d'amistat i de col·laboració professional.
Jordi, we have been collaborating and we have been friends for more than 30 years, and I hope that this
Aquí
is
estan els meus conflictes d'interès i aquest és el que volia comentar
what I wanted to talk about
en els propers 15 minuts.
The next 15 minutes.
El COVID-19 és una pandèmia, però també tenim una pandèmia de publicacions.
And there is a pandemic of publications. In barely 9 months, we have seen more than 80,000
revisades per parells,
publications.
Més totes les publicacions fetes a revistes preprint, més totes les notes de premsa. És a dir, hi ha una autèntica pandèmia d'informació que és molt difícil de digerir.
Hard to digest. On this slide, we can see that there are 3 clinical stages. One during the first week where the viral response is more preponderant. If things go well, you will be cured, but otherwise there will be severe inflammatory response, and then a procoagulant phase that might need some mechanical ventilation and can produce cardiac failure. And we have low molecular weight heparin in order to avoid thrombosis, and antivirals in the first stage. And then we need to administer anti-inflammatory drugs. In Catalonia, these are the data from the first wave. We used thousands of hydroxychloroquine, tocilizumab, LPV, RTV, which is antiretroviral, that brings together HIV and SARS-CoV-2, and remdesivir, and always with the faith of having it work, because we had in vitro data, but we did not have the cold blood, just like it was done in the UK, to have comparative studies with placebo to see whether to analyze whether the effectiveness of the treatments. And when these clinical surveys have been published, we have found some deceptions, because many of these aspects do not work, and what we administer is the remdesivir. And if we talk about the SARS-CoV-2 life cycle, there are very specific stages. At the beginning, endocytosis was with hydroxychloroquine was working, and the LPV RTV inhibited the proteinase, and the remdesivir inhibited some other elements. But chloroquine, hydroxychloroquine, and lopinavir do not work, and interferon doesn't work, and the convalescence plasma doesn't work. So we're running out of tools in order to treat these patients. And I recommend a free website from the New York Times, where they tell us which is the current situation of the coronavirus treatments and the vaccines in order to tackle coronavirus. These are data from last Sunday, and we have 22 drugs coexisting, but there's only 4 which are useful. Remdesivir with question marks, the convalescent plasma, and we have some data of clinical trials that show that it does not work. The monoclonal antibodies and the dexamethasone and other corticosteroids, that is the only medicine that has saved lives. Which was the role of the antiretrovirals, and which could bring together the HIV and the COVID-2 pandemics. And many professionals have treated patients considering that the antiretrovirals could be useful. The LPV was administered because it was effective in vitro and in animal models against SARS-CoV, and because there was a synergy with interferon beta 1b, and because the experienced practitioners in HIV had a lot of clinical experience, and they thought that these in vitro data that you can see here in micromolar level, they thought that this could be useful for SARS, MERS, and SARS-CoV-2. And they thought that this was not just the effect of lopinavir and ritonavir, but all the HIV antiretrovirals. And the Janssen labs told us that the darunavir had very little affinity with the SARS-CoV-2. And this was confirmed in later studies. You can see here to the left in the viral cultures how in green the inhibition of SARS-CoV-2 is at 0.5, and in darunavir at a concentration of 100 you can see 0 activity. And in clinical trials we can see that the proportion of negative samples of SARS-CoV-2 in respiratory diseases was the same in DRV as in the control group, so no benefits. We awaited for the results of lopinavir and ritonavir, and this was the first clinical trial which was published in the New England Journal of Medicine as antiviral treatment when faced with COVID, and they were frustrated because there was no reduction in the viral load in the respiratory tract, and there was no clinical improvement of the patients with respect to the control group. And this could be seen in the small Wuhan clinical trial, but in two large studies, in the recovery and the solidarity studies, which was published last week, where you can see the LPV, RTV with respect to the standard of care that doesn't show a reduction in mortality after 28 days, and there was no reduction in the admission of patients, severe patients in the ICU. So there is no activity, no benefit. And for remdesivir, the question is remdesivir, yes or not? That is the question. Remdesivir, for HIV experts, is really similar to tenofovir. It is the same mechanism or very similar. And we had a lot of high hopes for remdesivir because there was a clinical trial that showed really good in vitro results and in animal models when faced with SARS CoV-2 and MERS from a prophylactic and therapeutic agent. Remdesivir is filtered through the kidneys and it's not administered or not recommended with an eGFR below 30 milliliters per minute, and the dosage is 200 milligrams and then 100 milligrams every 24 hours during 5 and 10 days, and there are few side effects. And the most important clinical trial that motivated its usage in the developed countries is the ACT-1, the adaptive COVID-19 treatment trial, which was published 1 month ago. And it's a double-blind, randomized, placebo-controlled trial, which comes to show that if you administer remdesivir, you can reduce the time of recovery, the median time to recovery, and the mortality. And it was a randomized trial. 500 were administered remdesivir and 500 were in control. So it was approved urgently by the FDA and in Europe. The problem right now is that on the one hand, we have the ACT-1 funded by the NIH with positive results, and then we have the Solidarity published barely 1 week ago, the New England Journal, and with negative results. And you can see that two curves are overlapped. So which are the differences? As a result of the Solidarity results, which has been conducted by the World Health Organization. Obviously, the World Health Organization does not recommend the usage of remdesivir for COVID-19 patients. So do we use it or not? That's the question. So it's a very important question, but we can sort it out with different factors. This is the subgroups analysis. It's not the main analysis, it's the analysis by subgroups. So it has its own limitations, but it's true that the remdesivir introduces a more rapid recovery of the patients which had symptoms duration below 10 days of duration, and who were found in stage 5. They were receiving oxygen. In stage 6, they require mechanical ventilation, non-invasive ones, and stage 7, we're talking about the ones that receive the ventilation through a tube. So we can see that there is a clinical benefit in that stage. What happens with the WHO results if we compare both studies? The problem of the WHO is that they bring together two categories of the tryout, stage 5 and stage 6, with low and high flow. of oxygen. And there is benefit, but it's not statistically significant. But in the ACTT study, in the low flow oxygen with a mask without reservoir, there is a clinical benefit and a significant reduction of mortality, which is not the case in stage 6. But the WHO study brings together stage 5 and 6, and therefore this clinical benefit disappears. So we believe that remdesivir can be used for stage 5 patients with clinical benefits. And we have also had convalescent plasma transfusions with patients, thanks to patients with antibodies. But in the studies, no clinical benefit is shown in terms of reducing mortality on the left, nor in terms of introducing a clinical improvement of the patients to the right. So plasma cannot be helpful. The other thing that could help us is the monoclonal antibodies, which are neutralizing antibodies targeting the joining area of the SARS-CoV-2 cell and the recipient cell. And there are 2 large clinical studies with placebo control group, and there is a reduction of the need of admission to hospitals, and this can give us some hope for the non-severe patients, for high comorbidity or advanced age patients. It's an intravenous transmission, and probably the price will be higher. What about the antiviral prophylaxis? This has been really important. Hydroxychloroquine has been the star of the show. Hydroxychloroquine can prevent the transmission of SARS-CoV-2 and the cascade of symptoms. With exposure to patients with COVID-19, they have been using a pre-exposure prophylaxis strategy, and it has been published. And it was stopped because there was no clinical benefit in order to avoid the infection of healthcare workers. And we could see that it was stopped because it was the other way around. And we have some studies post-exposure when you have had a contact with a COVID-19 patient, and we can be talking about people living together with patients or healthcare workers. And the one below is a cluster analysis. Both studies show that HCQ given after 4 days of contact doesn't reduce progression of COVID-19. And if we pick the patients that are already diagnosed, so it cannot be used as prophylaxis pre-exposure nor post-exposure. And there are some clinical trials that tell us that it shouldn't be used for severe or mild or low patients. So it is no longer considered to be some kind of treatment for prevention nor treatment. And now we move on to HIV. And there is an observational study which has been done in Spain, published 3 months ago by Julia del Amo. And in this observational study, they analyze which is the risk of developing the disease and the degree of severity, depending on the kind of antiretroviral. And they take a look at the reverse transcriptase inhibitors. And in the patients, well, there is less diagnosis of COVID-19 and there are less admissions, and they show less severe impact, and this needs to be checked with some other studies. And the experience in Catalonia does not support these cases. And tenofovir in its formulation might work with the TDF-FTC. And there is a study of PrEP with healthcare workers that is being conducted in Spain. And to wrap up, The takeaway messages are that we're facing a pandemic of colossal challenges with millions of people infected. Antiretrovirals and hydroxychloroquine are not useful for treating COVID-19. Remdesivir is the only antiviral agent that has shown clinical efficiency against moderate and severe COVID-19, although it does not reduce mortality. And the hydroxychloroquine did not prevent SARS-CoV-2, and preliminary data of tenofovir need to be checked. I would like to thank all the colleagues that have contributed, and I would like to dedicate this presentation to the frontline healthcare providers and to our patients and their families. Thank you very much, Jordi, for this kind invitation.
Maria, per la...
Thank you very much, Josep Maria, for this brilliant summary of the treatment, and it reminds us of the first stages of AIDS with the expectations, and some were working well, some drugs were working well, some others didn't. I give the floor to Dr. Juliana Reyes from SACE-CAT, the coordinator of the technical unit of SACE-CAT, who is going to present some data that we have been working on in the last 6 months regarding both infections. Juliana, thank you very much, Jordi.
I aprofito per dir que si algú té preguntes...
I would like to make the most of the fact that if you have any questions, please use the Q&A chat. Some colleagues are already replying them on the go, and some of them will be answered later. Thank you very much, Jordi. I represent the SACE-CAT group. There's plenty of us, and we have been working intensely since the pandemic began. And in spite of the fact that this work is really intense, we have been brought together. And I think that we're a highly productive group where it's really nice to work with. And I feel proud to belong to the SACE-CAT for the last 5 years. I haven't been here for the last 25 years, and it's quite a challenge, everything that we're doing and everything that we'll be able to do, not just with HIV, but also with COVID. And thank you for showing us the way of public health in Catalonia. I'm going to introduce you the analyses that we have done with HIV and SARS from a syndemic perspective, taking into consideration many aspects that have been previously alluded to before. I'm going to say previously, I'm going to emphasize it again, but when we're talking about co-infection, we have had many different publications of HIV, and we can see that the prevalence of HIV in people infected by SARS-CoV-2 is 1%. And in Catalonia, a publication of barely 1 month from the primary healthcare unit describes that the prevalence of HIV patients with SARS-CoV-2 is 0.3%. When we're talking about primary healthcare data, which analyze the clinical data of people going to their general practitioner. So, in other words, we are underestimating the number of people that have HIV and SARS-CoV-2 in Catalonia. And then we have some data in some other studies where it is estimated that the prevalence of SARS or co-infection with HIV it's between 0.68 and 1.8, which is quite comparable to the data reported of prevalence of SARS-CoV-2 reported in the general population. And this has been compared with the studies from Iceland, which has been capable of testing all their population. So out of the multiple studies that have been published of HIV and SARS, one of the key ones, because it has a systematic review, is the one that was published in the H Behavior, but MISA, and there it brings together the top 25 studies where they describe the different characteristics of the co-infection, and they come to show that the mean of age is what you can see there, which is 52 years of age, and mainly male patients on antiretroviral treatment, and more than 60% have no multi-morbidity. When there is a morbidity, the highest percentage is hypertension, obesity, chronic obstructive pulmonary disease, diabetes, or cardiovascular disease. In terms of symptoms, the systematic review describes that the symptoms are similar to the general population, and the most frequent symptoms is fever, followed by cough, dyspnea, headache, and myalgia. And what differs with the general population, and there is one study which hasn't been published, but which is being reviewed. Well, it says that the severity can be higher in HIV patients than the general population, but we can see here in the systematic review that 66% of the co-infected patients have low or mild symptoms, and very few require admissions, and 11% require ICU admission. Out of all the infections reviewed, 64.7% requires intensive care unit admission, and only 64% require hospitalization, and 16% require intensive care unit admission. And it encompasses studies from Europe, Asia, one from Uganda, and from America, and it describes only 14.3% of mortality rates of the co-infected patients. So one important aspect of all these studies and this systematic review is that they analyze also the gender, and we can see that the clinical and epidemiological characteristics don't establish a distinction between male and female, so they're both equally infected, and the prognosis shows no distinction. In Catalonia, what we did in order to find out the situation of co-infection on a local level was to make use of the PICES cohort from a longitudinal study with diagnosed HIV patients treated in the units of all 16 public hospitals in Catalonia. There's 2 hospitals from the Balearic Islands participating, but we could not include them in the analysis. And these data were brought together to the integrated sanitary and healthcare information in Catalonia. And thanks to that, we could extract the data of infection by SARS-CoV, and in terms of the people that were hospitalized, admitted to the hospital, admitted to the ICUs, etc., because we have the registers of the epidemiological surveillance system from Catalonia, and we had the data of the laboratories and regarding the patients that received treatment. Out of the merging of all of these data, we were capable of reaching an N of 10,454 people that we have monitored with HIV, and that we can link to the registry system for the Catalonian healthcare service. And out of them, 452 had been diagnosed with SARS-CoV-2 through PCR or through antibody tests or clinical diagnosis. The analysis began at the beginning of the pandemic, and we still did not have clear definitions, and not everybody was being tested. That's why we used some diagnosis that reflected that there was an infection of coronavirus in people with HIV, and the co-infection prevalence was 4.32%. When we compare the people under monitoring with the co-infected patients, we can see that there is a higher prevalence for male, and the average age is 48 years, and the range is from 40 to 55. And the economic analysis or socioeconomic level is more or less the same. 48% do not have any socioeconomic constraints, but the co-infected ones, there is a higher percentage of people showing a socioeconomic level which is moderate or severe. We're talking about the least favored or most vulnerable segments of population. And in terms of HSH, the highest percentage of people in monitoring and co-infected are men having sex with men, followed by heterosexuals, and then drug abusing patients. And the average with HIV is 12.3 years living with HIV and only 6.2 years with antiretroviral treatment. One of the clinical characteristics that are important is that the monitored people in the cohort, out of them, only 9.75% have less than 350 at the moment of the analysis, whereas this proportion reaches 12.2% in the co-infected patients, and the non-detectable viral load is very important as well. And the backbone treatments, there is no difference in none of both groups. So until June the 23rd of 2020, which is this preliminary study that we conducted, at that time we had 10,464 adults being monitored, and we linked that to the Pisces-Patris cohort. Out of those, 452 were HIV patients, 384 managed on an outpatient basis, 88 asymptomatic, only 1% died. 383 recovered. Out of the 68 hospitalized patients, 5 were admitted to the ICU and 63 were not admitted to ICU. Out of them, 6 died. And in the ICU admissions cases, 2 died. So the non-symptomatic prevalence is 18%, the hospitalization rate 15%, mortality rate of 0.09%, and fatal rate of 2%. Which are the characteristics of the people when they are diagnosed, and how is it differentiated in the different stages or degrees of severity of the illness? What we can see is that the majority of them are male. The higher the prognosis, the higher the proportion of male, and the worst prognosis is between 40 and 64 years. And there are 2 people that died who were older than 75 years of age. So older people can have a higher risk of mortality, but with this small n number, it's hard to respond to that question. The largest proportion with worse prognosis based on origin come from Spain, and this proportion increases the worse that the prognosis becomes. And in terms of socioeconomic status, previously I told you that both the diagnosed and the ones which are being monitored, 50% of the population did not have a low socioeconomic level, but as the prognosis gets worse and hospitalization is required, or some ICU admissions take place, or there is a death, the proportion of people with low socioeconomic level increases, the worse the prognosis. In terms of HIV transmission groups, we can see that it's preponderantly male having sex with men. Even though this is reversed in terms of deaths, there is a highest percentage of people with drug substance injections. These are the most relevant features on a clinical and epidemiological aspects. One of the intense analyses that we performed was comorbidity, because thanks to this Patrice data, we could see the comorbidities and the different illnesses that patients had because of the diagnosis or progression to illness. And we can see that the cohort is healthy. 56% of all people did not have any comorbidity, and it is we can see that out of the ones that have comorbidities, which is approximately 43% and 53%, we can see that the highest percentage of illness, the ones which are the most diagnosed in the monitored people, we can see hypertension and kidney failure, cardiovascular diseases, respiratory diseases, COPD, asthma, diabetes, and liver-related illnesses, and viral hepatitis and obesity. And the proportion is similar in the co-infected people, but they change in the ones with the highest prognosis. Hypertension increases and cardiovascular diseases increase with a worse prognosis, as well as obesity. Just to analyze how all of this pans out from different perspectives and how these comorbidities are related, we did a latent class analysis in order to group the illnesses which are associated. If you are hypertense, you might have a higher risk of having kidney failure or suffering from a cardiovascular disease. So we grouped them together based on the ones that were the most related from a statistical standpoint. And in the class analysis, what we did was three groups. One group where 77% of our sample was relatively healthy. Some of them had some comorbidities and the majority had none. And then a group of cardiometabolic diseases, and then some groups with kidney and liver failures. And we can see that the worse the prognosis gets, from mild to severe to critical or to death, the cardiometabolic conditions and renal and liver disease see a higher representation. And if we do a logistic regression analysis, we can see that if we compare the ones that have at least one comorbidity against no comorbidities, and we don't adjust the result, we can see that the likelihood of having a COVID diagnosis is higher. And when you have an adjusted result using the latent or underlying classes that we have used to treat comorbidity, this likelihood of having COVID-19 diagnosis persists, especially for renal and liver diseases. But if we talk about severe prognosis with hospital admissions, cases of deaths, we can see that people with cardiometabolic conditions or renal and liver diseases, in all of them, adjusted or unadjusted, there is a higher probability of having a more severe prognosis of COVID-19. So all three questions and all three assumptions, well, all the three questions in the case of Catalonia had to do with the fact that CD4 is an important endpoint for COVID-19 diagnosis and severe outcomes. And we can see that if there is less than 150 CD4, there is a higher probability of having COVID-19 diagnosis and of having a worse diagnosis, a worse prognosis. And then the viral load. It can be associated to CD4, to the diagnosis and the prognosis. And we can see that CD4 are not significantly, statistically significant in terms of association. So there is no risk factor in terms of COVID-19 diagnosis and outcomes. And the other question, which was answered with the analysis that I presented to you before with the logistic regression. Here in this analysis, we see whether these people that have cardiometabolic conditions and some renal and liver diseases, where there is a higher likelihood of diagnosis and more probability of severe outcomes from COVID-19. And having a comorbidity has a stronger likelihood attached of having a more severe outcome or prognosis and diagnosis. And Dr. Miró and myself have been working together. This is the study that he was mentioning before of July. And this is a national cohort, and it indicates that tenofovir can be used as a protective treatment in order to improve the outcome for SARS-CoV patients. It might look like that, but one of the challenges posed is that they could not gather comorbidities, so the results are not adjusted based on comorbidities. So we do not truly know whether this is a bad interpretation due to the lack of adjustment, because what we know from tenofovir prescription is that it is administered to healthy people without renal and liver conditions. So we replicated this analysis, trying to compare and to measure the risk of diagnosis and worst prognosis in the patients with TDF and FTC, and we found that it doesn't protect for diagnosis nor symptoms, but there is a small signal that comes to show that TDF can be used to improve the prognosis of people with hospital admission. But here, that you can see that the range is quite wide and the results are not too robust. So these results need to be replicated. And we need to see whether we can be more precise. And we need to see whether the TDF, once we adjust based on comorbidities, can be used. And then what we did was to describe the cascade. We have the cascade of diagnosis and the testing rate. And we can see that for the states, the testing rate was 6.6%, and out of the confirmed ones, there was 2.01%, and the majority were symptomatic. And this comes to show that the people with HIV were not a key or strategic group for testing, and the policies that could be focused on improving the measures in order to avoid infection were not activated, because everything has been too complicated, and because until now, well, now we're beginning to think that the people living with HIV is a vulnerable population in terms of COVID and in need of specific measures. So as a conclusion, we need to state that the prevalence of SARS-CoV with people living with HIV is 4.3% of hospitalization admissions and 15% of mortality and 0.09 of lethal rate, a mortality rate of 0.09 and a fatal rate of 2% in Catalonia. There are no differences between people living with HIV and the people diagnosed with SARS-CoV infection. Nevertheless, the people living with HIV with worst outcomes have stronger comorbidities of cardiovascular and other kinds of diseases, with kidney diseases and liver diseases, and with CD4 lower than 350. And tenofovir in co-infection might play a role in the prognosis of COVID-19, but we need to perform more analysis. And at the end of the lockdown, people living with HIV were not considered as key population for the screening, and we would need to repeat the analysis in order to identify the changes of screening and the progression of screening in the population. And there is a lack of in-depth analysis in order to know the impact of SARS-CoV-2 in the rendering of services and the progression of the illness, because the SARS has had an important impact on healthcare provision, adherence to treatments, and the administration of medicines, and obviously there's going to be less viral suppression, and it's going to have a lot of impact, and it's important to measure that. And one of the last things is that in Catalonia, we consider the people living with HIV as a target population for these kinds of strategies. I would like to thank all the working group, especially all the group that has allowed this analysis to be possible, Jessica, Laia, Jordi. I would like to thank Dr. Miro for accompanying us all throughout these analyses, because they have guided us all the clinical part. And I would like to thank from Aguas Rosa, Elisenda, because they have allowed us to draw the link between Pisces and Patras. And I would like to thank you all.
Gràcies, Juliana, per la presentació.
Thank you very much, Juliana, for this presentation.
És que queda molta feina per fer.
One thing is clear, which is that there is a lot to be done. We have run out of time, and there are some people that need to leave. Sten, I know that you need to be elsewhere, so feel free.
I know you have already answered some questions. So we will proceed with the last communication. Daniela Rojas. Daniela és la cap del Servei de Recerca Comunitària de Coalition Plus, que ella ho comentarà, però és una gran organització no governamental molt compromesa amb VIH i la recerca comunitària, i ens presentarà precisament això que comentava la Juliana al final de la seva presentació, no? L'impacte de Covid sobre els serveis de VIH. Daniela, cuando quieras.
Gracias, Jordi. Bueno, esto de hablar la última es terrible. Tengo que evitar lo que una amiga mía llama muerte por PowerPoint. Así que espero estar a la altura. Buenas tardes a todos y todas. Estoy muy contenta de estar aquí con vosotros en este día. Gracias, Jordi, por la invitación. Para Coalition Plus es un honor trabajar con esta institución y es un placer particularmente trabajar con Jordi y sus equipos. Este año ha sido muy particular para todos y cada uno de nosotros, pero ha sido particularmente duro para las poblaciones clave. Y la presentación que voy a hacer hoy es una presentación, cierto, en parte técnica, pero también en parte política, como nos corresponde mucho a los comunitarios. La presentación de hoy va a versar sobre el impacto de esta nueva epidemia en los servicios comunitarios dedicados al VIH, y hablaré de diferentes organizaciones comunitarias, pero también voy a dar algunos ejemplos de mi institución, que es Coalition Plus, que es una organización una unión de organizaciones comunitarias que cuenta con 16 miembros de 16 países y que luego tiene partners en más de 100 partners ubicados en más de 50 países. Así que será una visión un poco internacional. A ver, para pasar. Los servicios comunitarios, ¿de qué hablamos cuando hacemos referencia a ellos? Los servicios comunitarios son aquellos que se caracterizan sobre todo por alcanzar a las poblaciones que se encuentran en los márgenes de la sociedad. Por ejemplo, aquellos que por su orientación sexual o por sus prácticas, como puede ser el consumo de drogas, no van a ser tratados por el sistema clásico de salud con el respeto que merecen. El enfoque comunitario, que sea en el terreno, en la investigación o en la incidencia política, tiene como objetivo final la transformación social. La idea es, en cierta manera, de cambiar el mundo y hacerlo un poquito mejor para asegurarnos de que la salud de estas personas está asegurada. Y esa transformación social solamente es posible gracias a la implicación significativa de las personas afectadas, infectadas o a riesgo en lo que al VIH, otras ITS y hepatitis se refiere, y va a permitir dos cuestiones fundamentales. Por un lado, identificar y responder a las necesidades de dichas poblaciones, pero sobre todo construir un puente que va a facilitar que dichas poblaciones puedan entrar en el sistema clásico de salud. Y para ello, la figura de los educadores claves, la inclusión de las poblaciones clave a lo largo de los diferentes procesos, el más fino conocimiento de las dificultades sociales y económicas, así como de la discriminación a la que se enfrentan esas poblaciones, son elementos fundamentales para poder asegurar esta complementariedad con el sistema tradicional. En lo que respecta al impacto a la sindemia, VIH y SARS-CoV, los colegas médicos ya han hablado de la evidencia y de dónde nos encontramos, una evidencia que además evoluciona a una velocidad vertiginosa. Pero más allá del impacto biológico, aquellos de nosotros que estamos trabajando en el ámbito de las ciencias sociales, de la epidemiología, tenemos que recordar y afirmar la necesidad imperiosa de recoger y de tratar datos que nos van a permitir identificar, evaluar, medir, cuantificar los determinantes sociales de esta epidemia. Sin ninguna sorpresa, las personas en situación de precariedad, de marginalidad, son más susceptibles a la enfermedad y a sus consecuencias negativas. Desafortunadamente, lo que nosotros oímos, por ejemplo, de algunos colegas de América Latina, es cómo se enfrentan en ocasiones a una voluntad expresa y manifiesta de no medir determinadas variables socioeconómicas, lo que impide conocer determinadas realidades y, sin ninguna duda, imposibilita que podamos poner en marcha soluciones que permitan la prevención y el mejor cuidado de las personas. Por otra parte, la crisis sanitaria provocada por el SARS-CoV-2 ha tenido un impacto socioeconómico mayor y ha provocado dificultades de acceso a los servicios de salud esenciales para múltiples patologías, incluido el VIH. En lo que se refiere a nuestra red, por ejemplo, los compañeros de la ANSS en Burundi nos informan de actuales rupturas de stock de antirretrovirales y otros países, como Burkina Faso, prevén la llegada de estas rupturas de stock en las semanas o meses que van a llegar. En Bolivia, Ecuador y Marruecos, estructuras históricas de lucha contra el VIH como IDH, quimirina o la ALCS han observado una precarización brutal en las poblaciones clave, particularmente en los y las trabajadoras del sexo. En Francia, los colegas de ED han observado un aumento de las violencias ejercidas hacia los usuarios de drogas y los trabajadores y trabajadoras del sexo. Por dar un ejemplo, el estudio EPIC, con una muestra muy pequeñita, pero el dato es interesante, mostró que entre los y las trabajadoras del sexo, un 81% declaraba una disminución de los ingresos y un 21% declaraba un aumento de al menos un tipo de violencia por parte de los clientes. Creo que eso todo hace referencia a lo que Jordi hablaba al comienzo de esa sesión sobre el tema del concepto de sindemia. Y llegó la COVID. Una pandemia que, como otras epidemias en otros momentos de la historia, dejará secuelas físicas, mentales, sociales, económicas, que no llegamos aún a evaluar y cuantificar. Una pandemia que ha sesgado la vida de más de 1,5 millones de personas y que ha puesto en jaque a gobiernos, población y actores de la salud pública. Y todo esto en un contexto donde forzosamente se va a producir una competencia entre los recursos y el tiempo dedicados a la COVID en detrimento de otras patologías. Y así nos encontramos, y es una cuestión que oímos constantemente en los miembros de Coalición Plus, por ejemplo, esta distinción entre los enfermos COVID y los enfermos no COVID. Y la necesidad que vamos a tener de anticipar cuán grande va a ser la recesión económica de los donantes públicos y privados en los meses y años futuros en lo que se refiere a la lucha contra el VIH. Para poner las cosas todavía un poco más difíciles, la crisis sanitaria generada por el SARS-CoV-2 ha venido a señalar fallas, fragilidades, ha mostrado hasta qué punto la falta de inversión en los sistemas públicos de salud y la persistencia de profundas desigualdades económicas y sociales son una realidad. Así que veamos, esto lo presentaba antes un poco Anastasia, mi querido compañero y amigo Daniel Simoes ha publicado este paper en el que muestra cómo en el periodo comprendido entre marzo y mayo del 2020, 41 de 52 centros comunitarios europeos y 19 de 36 centros de salud secundarios informaron de graves perturbaciones en sus actividades de screening del VIH. Y esto es fatal, como lo decía Anastasia antes. Las principales razones de esa disminución de las actividades de screening fueron una menor orientación de pacientes de un centro a otro, el hecho de que algunos centros tuvieron que cerrar durante el confinamiento, la reducción de personal a nivel comunitario, la ausencia de servicios sin cita previa y la sobrecarga de los laboratorios. Eso, por ejemplo, en Francia lo hemos observado muchísimo, como los laboratorios no pueden dar abasto. En Francia, unos resultados publicados por Santé Publique France y Coalition Plus el 1 de diciembre muestra que entre los 8.345 hombres gays que respondieron a la encuesta SARS-COVID, un tercio declaraba haber pospuesto una prueba de VIH o de ITS, y una proporción similar, un 35%, de HSH que vivían con VIH informaron haber pospuesto o cancelado su visita de seguimiento por el VIH. Sin embargo, las interrupciones de tratamiento fueron poco frecuentes, menos de un 3%, y de manera similar, en el caso de los usuarios de PrEP, un 60% de personas pararon la PrEP, principalmente debido a la ausencia de vida sexual, porque hubo un respeto del confinamiento, y, sin embargo, hubo un 6% que sí que informó haber parado la PrEP porque no hubo manera de acceder al medicamento. Tal como indicaba Annie Belter en la conclusión de este paper, si la pandemia ha tenido un impacto significativo en los servicios de pruebas y screening de VIH, su impacto en los tratamientos de VIH ha sido menor de lo que se temía originalmente, gracias en parte a las adaptaciones realizadas por los servicios de salud basados en la comunidad. Y esto hace referencia, por ejemplo, al acompañamiento de los usuarios de PrEP o la dispensación de test por algunas ONGs como EDA. Ahora bien, los trabajadores comunitarios de la salud son, en cierta manera, el eslabón más bajo de la pirámide de la salud, a pesar de tener un trabajo crucial que es el de facilitar la entrada en el sistema de salud de las poblaciones clave. Tal y como indica Luisa Sagaón en este paper publicado recientemente, la eficacia de las respuestas a las epidemias y, en general, la eficacia de las estrategias de salud pública en los planos nacional y local depende de la capacidad del personal sanitario para desempeñar plena y competentemente sus funciones dentro del sistema de atención de la salud. Sin embargo, la carga laboral y emocional, la incertidumbre sobre la capacidad de realizar el trabajo necesario tienen un impacto enorme en la salud mental y el bienestar psicológico de los trabajadores comunitarios, incluyendo los médicos. Los trabajadores y trabajadoras comunitarias deben ser vistos no solamente como un instrumento para la lucha contra las epidemias, sino también como una población a proteger, porque en parte ellos también son representantes de las poblaciones clave. Como podéis ver ahí, por ejemplo, entre el personal sanitario de nuestra estructura en Mali, encontrábamos unos porcentajes de alrededor del 70% que declaraba síntomas de depresión, ansiedad o insomnio. En todo caso, en estos últimos meses hemos observado un gran abanico de adaptaciones en los servicios comunitarios con el reto de no interrumpir o de interrumpir lo menos posible la respuesta a la epidemia VIH en medio de la epidemia COVID. Las respuestas que hemos visto en Europa no les son únicas. En África del Oeste, Este y Centro, en Oceanía, en América Latina se han observado iniciativas similares y otras diferentes de las que hemos visto aquí en Europa. Así, las estructuras comunitarias, por ejemplo, han puesto en marcha actividades de telemedicina en Ecuador. Por ejemplo, en Ecuador, donde recientemente se había autorizado la PrEP, durante este periodo del COVID se hicieron consultas virtuales para justamente continuar proponiendo la PrEP y garantizar que la gente que ya estaba tuviera acceso a ella. En Bolivia hubo experiencias como el CoronaPsi, que fueron webinars para proteger y cuidar la salud mental de determinadas personas. Todas estas eran actividades que antes no existían o que hubiera costado mucho más tiempo desarrollarlas. Luego ha habido también un cambio en la
there has been a change in the frequency of condoms and retrovirals, and more self-tests have been dispensed. We have seen some campaigns of screening, like the ED campaign that you can see here, and we have seen more strict selection of the criteria, and we have seen some experiences of distribution of methadone and some retroviral drugs, a long-withstanding battle. And not only have we seen some adaptations in the activities of the structures, but there was a need to surmount the difficulties of the states in my structure, and this is a humble experience. From April 2020, an emergency fund was established using the Agence Française de Développement, and the creation of this fund had the purpose of ensuring a minimum service package so that the people living with HIV and so that the awareness raising and dissemination practices and the response to basic and therapeutic needs would be guaranteed. A total of 1.4 million euros were distributed to 45 community organizations that made up the Plus association or network of association, and we're talking about food for the most marginalized, and there was a social transformation activity that turned a humanitarian activity, and this was complementary to several other activities. Here, how can we move forward in a context where we are talking about the acceleration of demedicalization, the pace followed by the reporters, by the politicians, by researchers is different. So I leave you with 3 takeaways here. It's important to delegate different tasks. It was already a need before the COVID pandemic, and it's going to be an important ally if we want to make sure that there is continuity in prevention, and if we want to continue with better services where there is, where we're talking about overwhelmed healthcare services. The acceleration of demedicalization and to reach the certain populations is very important, and we need a better integration of community-based services into the national health offers. Community-based research in time of SARS-CoV is a new challenge. The expertise of the community-based services has been acknowledged, but it needs to become a tangible reality thanks to funding. And we need data in order to underpin the policies. The studies conducted by many different public healthcare institutions and other kinds of institutions should help in the decision-making process in order to adapt the responses for the most vulnerable. For our part, we have launched a community-based research project called EPIC in order to measure the impact in key populations, together with some partners. Of course, SACE-CAT is one of them. So, Jordi, we have work to do for the next 25 years. Thank you very much. Thank you very much, Daniela.
Fantástica presentación.
For this wonderful presentation. We have gone over the schedule. I think we all need to learn to better master these digital tools. In any case, we're going to give the floor to the questions. There have been some questions addressed to the first speakers, but they have been answered via chat. I'm going to share a few. There was a question from Daniel to Anastasia saying, is there any hypothesis that explains why mortality between migrants is higher? Especially taking into consideration that in sub-Saharan Africa, the counterparts in their native countries have had a minor degree of clinical severity. And Anastasia was answering, well, we have data on mortality of very few countries, Great Britain and Sweden. It's probable that some of the high mortality rate impacts might be the result of access to healthcare service access and the subdiagnosis of comorbidities. We need to work more on that in order to understand the mechanisms that underpin this information in the different European countries, just to compare. And one question which was related to a very important topic. Lourdes Ferrer said, good afternoon, really interesting, all the presentations, and in the case of SIDAS, it took a while to reduce mortality. And in the case of COVID, we can see some objectivation of certain symptoms which are prolonged throughout the year. What do we know about chronification of the epidemic? And this was a question of Sten, and the question is, and the answer is, there are tens of thousands of people who have survived COVID-19 and are now being followed to study long-term effects. I think we do not yet know what we will learn from this in the next months and years. And I hope that in the next months and years we can learn a bit more. Therefore, in order not to protract this any longer, because there are some people that need to leave, I would like to thank you again to all that have participated and for the great work that you have put in and the great collaboration. And I hope that we can continue to collaborate. It is a pleasure when the collaborations and the scientific rigor become friendships, and everybody present here comes to show that this is a reality. So Sten, Anastasia, Giuseppe Maria, Juliana, thank you very much to you all for sharing your knowledge and for accompanying us all throughout these years. I would like to give the floor to close this session to two persons that represent the research part from SESCAT, from the humble monitoring perspective, when we have Dr. Jordi Barratina, the director of Germans Trias i Pujol Research Center, which encompasses half of the team. And this is the area where we manage and we develop the external research centers. Jordi, thank you very much for holding on. Thank you very much. I have enjoyed this session. And I acknowledge that for those of us that do not follow up all the knowledge generated, this is extremely useful. I'm going to try and cut it short. Basically, I would like to comment three things. Obviously, I would like to thank and congratulate the SACE-CAT.
Jo soc de les últimes persones a incorporar-me al campus, recentment com a director de l'Institut Germans Trias i Pujol, però...
I'm one of the last people to participate in this center. And when I began my training as researcher, I was witness to the beginnings of the SACE-CAT when I was receiving training as a researcher. And I was working on HIV research, so I was a witness of the first years, and it's really satisfactory and really interesting to see the trajectory that you have followed. It's really difficult to generate this trajectory, and there has been good and bad times, but obviously we need to celebrate as we should. So congratulations, and thank you very much for allowing me to participate. And secondly, as director of the LGTP, I would like to tell you that from now onwards, and for the next 25 years, we hope that you feel at ease and that you work as comfortably as possible so that we can continue to be reference for your work. And I would like to highlight as well the task of knowledge transfer. Oftentimes we talk more and more about knowledge transfer, and we talk about patent generation. But I believe that in your case, all this work of monitoring and strategic response shows an example that it is a task that is sometimes neglected or sidelined, and it has been shown that it is generating a lot of knowledge in order to be able to make the best decisions, and this is a good transition to a manager that has to close today's event. Thank you very much for inviting me over. Thank you very much, Jordi. Before giving the floor to Dr. Fabregat to close this session, I would like to thank on behalf of all the team through an email for all the support, and I would like to thank all the team of SACE-CAT, including everyone in the microbiology service who are working very closely on the projects that are beginning. Thank you very much. Just to wrap up, I would like to give the floor to Dr. Rubén Fabregat, the Director General for Research and Innovation in Health, and with whom we have a close relationship because of this syndemic between COVID and HIV that we're exposed to. Thank you very much. Thank you very much, Jordi. Lately, it's as if I am part of the SACE-CAT team because we're holding daily meetings. First, I would like to thank you for inviting me on this closing moment. We're celebrating 25 years of history of SACE-CAT. There are not many institutions that can celebrate 25 years of successful history. So I would like to thank you for this effort. And I would like to thank you, Dr. Casabona. It's not easy to lead a project like this. I could connect from 5, not from the beginning. I could not be here before, and we can see many reasons for taking pride in the history of SACE-CAT. And when it was created in 1995, it was a necessary bet. And it was necessary to have better tools in order to fight against AIDS, but it is clear to see, and we have seen that it was a necessary intervention throughout these 25 years in order to reinforce the strategies in public strategies that have been boosted. And in the last months that Jordi and myself have been capable of collaborating, it's essential that if we can have science-based epidemiological data, this is essential in order to design and monitor epidemics like the current one, and in order to streamline the best intervention strategies. More than anything, for the people that do not know the SACE-CAT, you should know that institutions like this center are essential. We're living an international global pandemic, and the SACE-CAT has shown the importance of the work and the know-how that they can contribute with to the system and to the citizens, brandishing different initiatives with the goal of providing with the most amount of data in order to underpin the policies and strategies. And I know that the monitoring program has been an example, and the program for prevention, control, and care for HIV, and then the Sentinel School project that is going to allow us to have a lot of data in order to continue to place a bet on important decisions that foster equality so that the children can also continue to receive education at school. So we are trying to guarantee equal opportunities, and the SACE-CAT is working along these lines. And we have seen the international acknowledgement and prestige that SACE-CAT. We have had almost 200 people from different countries of Europe and America, with the participation of great institutions and great professionals. And this comes to show that this vision is worth a while. With a focus on public health care, the infectious diseases like COVID understand of no boundaries, and we need to find ways in which we can share knowledge. And at the same time, this is the best way in which we can place on the map the level of excellence that we have in Catalonia in research and the Catalan system for health. And if you allow me, in order to wrap up, I would like to highlight, and for me, this is one of the most important virtues of SACE-CAT, which is the vision of country that we have, the vision of system that we have to understand and to be understood in SACE-CAT as a tool at the service of the citizens, bestowed with the tools necessary to tackle the challenges current and future. And the SACE-CAT was created in order to have better and more tools to fight against HIV. And we have been bestowed with better tools to fight against HIV, STDs, and viral hepatitis. We don't know what the future holds in store for us, but if there is any lesson learned from this COVID-19 pandemic, is that we need to be bestowed with more tools from the public healthcare service in order to face these challenges. And the SACE-CAT is going to be as important or more important in the years to come. So congratulations for today's event, and thank you very much for all the work that you're going to undertake, at least for the next 25 years. Thank you very much to you all.
Jordi, crec que estàs silenciat, perdona.
No, deia que moltes gràcies a tots.
Thank you very much to you all. I hope that you can count on the SACE-CAT for the next 25 years, but don't count on me for the next 25 years. You can count me out, I'm afraid. But on the other hand, usually if we meet face to face, there is a coffee waiting for us outside. But thank you very much for being here and for being present all the time, because this is something that in our context is really difficult for managers. But I think that it's really good and positive for both sides. So thank you very much, and thank you very much for the attendees, and again to all the team. Thank you very much. And we will try to celebrate it 5 years from now. Let's see if it's not so difficult. Thank you very much.
Adeu, Jordi.
Adeu. Bye-bye, Daniela.
Chao, Jordi, hablamos.
Sí. Anastasia, if you are still here, thanks a lot.
Adiós, Jordi.
Adiós. Hola, Julián.